Please, Bill.
Thank you. Thank you, Giancarlo. I didn't have my microphone on there, but I think it's interesting that question about whether to stent that or not is an interesting one. I think if I did a case like this the other day where I actually did stent that because access was so difficult. It was a critical limb ischemia patient. The difficulty getting in and out was too much to want to come back. Okay, so 10 minutes to describe programs that have two programs that have each taken multiple years to develop. Here are my disclosures. So we know that DES outcomes in the SFA lag way behind the coronary outcomes, and there are multiple reasons for that. A lot of them have to do with the uniqueness of the pathology, biology, and the time course of restenosis in the SFA as compared to the coronaries. Eluvia, which I'm going to start with as a DES platform, really was kind of purpose-built for this SFA. It wasn't kind of retrofitted in from another application. It's the recognition of a unique SFA environment, a stent which is made for that environment, biocompatible coating which can be tuned in terms of elution, and all in all should provide a good clinical outcome. We know that from Giancarlo and Dirk's work over a decade ago now that stent fracture does occur. It occurs in association with restenosis. Although this is less prevalent now, most of the data we have is not with overlapping stents and multiple long lesions, so I would submit that this is probably underestimated, nevertheless less than it used to be. We do also know that as compared to coronary disease, where the restenosis rates really start to peak in the 3 to 6 month range, we have restenosis rates in the SFA which really peak in the 9 to 12 month range. So there's something different about the biology and something very different that needs to be addressed for our devices. And we also know now, as compared to the first generation coronary stents, that there are multiple polymers available, both biodegradable and durable, which are safe and effective and can be actually well tuned to the environment. So if you look at the various design considerations between coronary and SFA, which were looked at with the design of Eluvia, all these things were brought into play: mechanical environment, the pathologic differences, the disease progression. And you can see that overall the device is now custom fit for the SFA. The Eluvia stent is based on the Innova stent design, which is closed cell on the ends and open cell in the middle for flexibility and meant to address the environment in which it's placed. The coating design, there were multiple choices for coating, but the coating design basically is a primary layer, which is a primer, does not have drug on it or does not elute, serves as an adhesion layer for the actual elution layer, which controls the release and can be tuned. And apropos of the long tail for restenosis in SFA, Eluvia has a 360-day drug release profile as compared to both Zilver PTX, which has no polymer and has a burst of paclitaxel delivery, and DCB, which obviously has no polymer either. So these two reside in the tissue based on their initial presentation, as opposed to Eluvia, which elutes over time. This has led to a clinical trial called the Majestic trial, which was run in Europe, and the details of which were given over a year ago. The 1-year patency, primary patency, which is a combination of binary restenosis and the absence of binary restenosis and the freedom from TLR, was 96.4% at 12 months. Oops, okay. As we look, taking that data set from a first-in-man and trying to figure out what to do with a pivotal trial, I'm not going to go through all of this, but I will tell you we knocked our heads around a little bit because now we have this really good event rate, a very low event rate in a kind of first-in-man experience. What do we go up against as a control? Bare metal stent, drug-coated balloon, atherectomy plus DCB, DES, and so on. And we wanted to enrich the environment so that we could actually count events and understand the efficacy of each device. So in the end, the decision was made to go DES versus DES, and I think I applaud this decision from Boston Scientific. I think it allows us to, for the first time in the antiproliferative era, to have a head-to-head comparison between therapies. All of us stand up here and give you large panels, and I'm going to do that in a minute, of trials which were not head-to-head. They're really not easily comparable. Endpoints are different, measurement of endpoints are different, and populations are different. But in here, we get rid of all that, and you're going to have a head-to-head between two very good therapies. So it's a randomized trial. I'm privileged to be the global PI along with Dr. Stefan Miller-Hulsbeck. And it's a fairly standard trial, 2-to-1 randomization, Eluvia to Zilver in the SFA proximal popliteal arteries. These are the devices. The only real differences is the biostable polymer and the lengths, which are a little bit longer in Eluvia. I'm happy to say that this trial is now fully enrolled as of February of 2017, 465 subjects. Again, kudos to Boston Scientific for getting this done in record time, and we await results next year. So the conclusion for Eluvia DES is that this imperial trial will give us the first head-to-head data set in the antiproliferative therapy, and we have longer lesions, which will be assessed with the Eluvia stent, will also be looked at in separate analysis. So moving now to DES. There's been an evolution in understanding about, DCB, evolution in understanding about paclitaxel coatings and drug-coated balloons. So you can see here multiple different types of paclitaxel arrangements and formulations, from macrocrystalline, which is kind of the purest form, amorphous, which is more of a paste, hybrid coating between the two. You can have all sorts of microcrystalline, nanoencapsulation. All of these are potentially valuable, and I think now there's much more information about how the effectiveness of these plays out. And here's a little example, really drawing between the two poles of the different formulations, crystalline coating on one hand, amorphous coating on the other. The crystalline coating has lots of particulate release, generally is characterized that way, amorphous less so. More difficult to get a uniform coating with crystalline, less so with amorphous. The transfer to the drug to vessel is quite good in both. Drug retention time is excellent in crystalline, needs work in amorphous. The effectiveness is better with crystalline and vascular toxicity. And I remind everybody that the original Pacocath was a very inhomogeneous crystalline balloon paclitaxel construct. We also know, and I love this diagram, we also know that with increasing doses of excipient, you get fewer particulate counts, and actually dose density doesn't seem to affect particulate count as much as excipient does. Looking at the 4 drug-coated balloons here, you see them all ranged here, and 2 of them are approved, 2 of them are, one of them is an imminent in Spectranetics Stellarex, and the Ranger is still in study. They all have different coatings. Most of them are over the wire 030, 035. Ranger is 014, 018. I think the important differences here are really that the FDA approval is not yet available. This is the Transpax coating, which is a ATBC coating, trying to balance the hydrophilic and hydrophobic qualities of the excipient, which is really what the excipient does. It merges the hydrophobic moiety of the paclitaxel with the hydrophilic wall. Here's some of the preclinical testing. You can see that the Transpac coating seems to adhere nicely to the balloon during hydration, as opposed to some of the flaking that occurs in other balloons. Whether this has a biologic effect or not remains to be seen. And as in DES therapeutics, the tuning was really to try to deliver as long as possible tissue residence within the vessel wall, and it's comparable to the impact balloon. There's a whole clinical program. I'm not going to go through all of it. There is some data now from the Ranger SFA trial I want to go through and talk briefly about the Ranger 2 global pivotal. So this is the Ranger SFA study. This is the primary efficacy endpoint at 6 months. This is fairly standard for a DCB. The primary endpoints are typically late lumen loss with a secondary endpoints of comparison with standard balloon on both that and outcomes. And you can see the late lumen loss was about right for the control balloon, about 0.8. They range about 0.9 or so in most studies, and 0 to negative late lumen loss at 6 months for the Ranger SFA. And if we put that in context, you can see here that in point of fact, it looks quite good for the late lumen loss. Both the Impact and Ranger had basically 0 late lumen loss. 6-month TLR also looks quite good. I'm going to go to this slide to show you that. Freedom from TLR at 6 months was 91% as opposed to standard balloon angioplasty of 70%. And this is primary patency, the combination of TLR and binary stenosis freedom. And you can see here again excellent outcomes at 1 year at 86% primary patency. As we compare this to others, and this is the chart I promised to show you, although I'll criticize it all day, you can see that in point of fact, the Ranger SFA study lines up quite well with the existing technologies, as does the TLR. Here's the global pivotal trial. Principal investigators Tomas Zeller and Ravish Sakar in the US, and this is a 3-to-1 randomization of balloon angioplasty to Ranger, and in almost 400 patients. This is the rest of the sponsored research by Boston Scientific, hemodialysis, lots of other SFA trials, and BTK. And to wrap up, Ranger intends to take advantage of the advances in coding and excipient understanding for DCB construction. Initial clinical results confirm effectiveness comparable to existing DCBs, and Ranger 2 and other investigations will further extend this study. Thank you very much.